Okay, good evening, everyone. Thank you and welcome to yet another Thursday evening webinar sponsored by Clinix Health Group. I think this is a time that we are already so used to after 3-4 years of running the webinars. And I think the reason we are continuing as Clinix Health Group to run these webinars is because of your attendance, your regular attendance. And for as long as we have the audiences that we get and the demand, the calls and the emails and the messages that we receive from you, giving us topics that we should cover, also suggesting speakers, we really welcome it. And those who want to continue sending us topics that we would like covered, and even if you got speakers, or if you want to volunteer yourself as future speakers, please do contact us on webinars@clinix.co.za, webinars@clinix.co.za, and then we'll put the message also on our chat box today. But we're still letting some of our participants in, but I see we've already got just over 300 participants now. And we will go through the presentation, which will last about 45 minutes or so to an hour. But during the presentation, we will mute everyone. And then, but during the presentation, whilst you are muted, you can still put your questions, type your questions or comments in the chat box. And we will attend to them at the end of when our speaker for today is done, and then during the questions and answer session, we will attend to your comments and answers. We welcome those who have registered using the link that we sent, because it's important that you register yourself. If you have received the link second-hand or third-hand from someone, you are welcome, but you may not receive CPD points if you have not registered yourself. Because when you register, it takes about 1 minute to 2 minutes, and the registration system requires your registering body's number. If you are HPCSA, for instance, you would have to type in your HPCSA number. And we say this again and again because we get new attendees almost with each and every webinar. And the other thing is that we also continue to receive faulty ones where people do attend, but they don't receive their CPD points. And then when we inquire, they find that they did not use the correct HPCSA number, or they got the link from someone, or they use their practice number, which they get from BHF, which won't work this time. So instead of your practice number, please put in your HPCSA number or your South African Nursing Council number, or if you are in the nursing profession, or if you are in the pharmacy, you can put in your pharmacy council number. I think those are the ones that would work and make sure that you have received the points that you deserve. And today, I'm glad to say that we are happy to have our speaker today, Professor Judith Prof, who is going to speak to us on a topic that I think all of us still lack when we check the quality of the CPD points that we receive, because we know that we get clinical CPD points, but we also get ethics CPD points, which I think most of us, HPCSA, those who are registered with the HPCSA, will always remind you that you are okay with your clinical points, but you are lagging behind with ethics points. So, and we have had a request for a topic on ethics, and this is what we are having today. Professor Judith Bruce is going to speak on ethics in practice. And we know how important that is. I know in medical school, we don't hear a lot in our syllabus about ethics, but we know that once we are in practice, it's very important. Professor Bruce is a visiting professor in the School of Therapeutic Sciences at the Faculty of Health Sciences with VET, University of Witwatersrand, and she's a past president, vice president of the Academy of Nursing of South Africa, and she's also, I know her also because we work together, Prof, in as one of the clinical risk committee members who assist with quality care and ensuring that we attend to all adverse events that happen within the clinical practice in our facilities. And I think you're doing a fantastic job. But further on, Prof. Bruce is a respected leader in nursing education, academic mentoring, and health development. With over 25 years of impact across South Africa and internationally as well. She's currently, as we said, the visiting professor at the School of Therapeutics at VETS, and she played a key role in strengthening nursing education, developing academic programs, and mentoring future nurse leaders and academics in our country. Her influence spans nationally and internationally, including contributions to nursing education policy, workforce development, and specialist postgraduate training across Sub-Saharan Africa. She's also a passionate advocate for professional recognition, for equity, and compassionate nursing practice. Among her many honors, she was inducted as a fellow of the American Academy of Nursing, and she's only one of 3 South Africans who have been inducted into the American Academy of Nursing. Prof, I think over to you. Thank you very much.
Thank you, Dr. Kanoshi. It almost sounds like I've never nursed before, but I have. Yeah, thank you, colleagues, and welcome to this webinar. I thought by way of introduction and to set the scene, I'll just give a bit of background to the webinar. I just want to get this out of the way. Yeah, there we go. Just put it over there. Right. So this webinar essentially builds on previous talks, and the most recent was to the Clinix nursing group across the country, I think. And so I was asked to do this evening. And so essentially, I am mindful that this webinar is reaching an audience that's wider than just nurses, but I consider us all as professionals accountable for our own practice. And so what you will take from this webinar, you will adapt and apply it in your own practice. From a personal perspective, I won't say how many years I've been a nurse, but just to say that my background is in the emergency care environment, and that is a particular environment where ethics become quite a gray area. And so that has really shaped who I am today. So colleagues, the presentation is largely then through a nursing lens, but I'm sure there will be some pearls that you will be able to use and apply in your own practice. All right, so what you can expect this evening is just a clarification on ethics and other related concepts to ethics so that we all can be on the same page as we progress through the webinar. Stemming from that, I will address aspects that make up ethical and unethical conduct. We will look at why ethics actually matters in practice, and I will focus particularly on the South African context and look at some of the challenges that may compromise our practice in terms of being ethical, and then also systems imperatives, which will really be around professional issues, politics, and so forth. Then we will take a look at core ethical principles, and I will have some examples of how that works in practice. At the tail end of the presentation, we will look at the generic decision-making framework when we're confronted with an ethical issue. And if there's time, Dr. Kanoshi, I would like to share two very fundamental, very basic case studies that profiles ethical risks and a dilemma. Right, so let's begin then. What do we understand by ethics? And I'm sure this is just a revision for many of you. It's really regarded as a system of moral principles that balances right and wrong. And these principles thus govern our behavior or our conduct in practice, our decision making, and so forth. And so it helps us then in the process to distinguish between what is right or wrong behavior and what is acceptable or unacceptable behavior. Now, I want to hasten to add that we're not going to look at ethics as a philosophical discipline, but just as a reminder that ethics is, in fact, a branch of philosophy, but we will not be looking at those philosophical, but rather have a pragmatic approach to ethics this evening. So there's about 6 ethical concepts that I would just like to clarify. And the first one is values, very inextricably linked to ethics. Now, values are deep-held beliefs, core beliefs that guide our behavior. And these may be personal or professional values. And because values are influenced by many, many things, they evolve and may change over time. Values also inform our model development. And so let's look at morals. Morals are really standards or beacons of what's right or wrong. They guide our conduct again. And as I've already said, it is shaped by one's values. Now, morals in turn inform our sense of duty, which really is about a moral obligation for us to act in the right way all the time or most of the time. Behavior, just so we're on the same page again, is a person's observable response, action, and reaction to their environment. And I want to hasten to add here that non-action is also a form of behavior. Ethical principles, they are really fundamental guidelines which are rooted, they really have their origin in our moral values, and they also in turn govern and inform our behavior and decision making. Now, our professional bodies, the HPCSA, the Nursing Council, the Pharmacy Council, use these ethical principles to formulate codes of ethics. And so these codes are really considered as a formal set of guidelines which are designed, and many won't believe this, but to support and protect us as professionals from any possible wrongdoing. So in a way, these codes of ethics then serve as guardrails for our practice. I do want to mention rights as well, because it will come up again. Rights are really entitlements that protect individuals, and in particular our patients. There are negative rights, which really is about protecting individuals against non-interference or preventing governments and other people to interfere with rights. And so we think particularly of freedoms, not curtailing freedoms of expression, freedom of movement, and so forth. Positive rights, on the other hand, is one's right to service, one's right to life, and so forth. And all of these concepts, colleagues, are ones that we'd like to embody and become ethical practitioners. So if I liken ethics to an ethical practice tree, we can almost look at the values and consider those as rooted in soil. And in fact, they are shaped by a whole lot of things. And so the soil and everything we add to the soil help us to develop a set of values. We think particularly of family upbringing and teachings in families, and colleagues, you were all aware how we are concerned about family structures and the disintegration of families in our societies and communities, and these in turn impact on value formation already at that early level of people's growth and development. There are a variety of cultural beliefs, religion, one's life experiences, principles of Ubuntu, and also our education and other forms of learning and professional socialization also shape our value systems in turn. And then, as I said, models come from values, and models then determine how we conduct ourselves in practice. So ethical principles can be considered as the branches, and those ethical principles then shape our conduct in practice, which are represented there by the leaves. On the sides there, you see the guardrails of ethical codes, but we can add to that. There are policies, guidelines, laws that also act as guardrails. Now, if we want to be very optimistic, we can consider the outcomes of or the impact of our conduct as being fruitful in terms of patient outcomes. We do want our conduct to benefit patients, benefit the healthcare team, and also the organizations for which we work. So, when do we consider conduct as being ethical? So, once actions, decisions, or behavior align with established models and ethical principles, and the end point always, colleagues, is to promote the well-being of others, and in this context, our patients. There are three main alignment. There are others, but I've cherry-picked only these three. So when there is value consistency, it means our actions and our decisions match personal, organizational, or societal values. So there must be value consistency, and that then enables us to behave in an ethical manner. And I just give an example there of honesty. Also, when principles cohere or adhere together, when so your conduct is considered as ethical when we observe fundamental ethical principles such as autonomy and veracity. Also, conduct is ethical when in our practice we minimize harm, and this will come up almost all the time, where we actively prevent, reduce, or avoid adversity or harm happening to others. So when is conduct then considered unethical? So it's again when one's action now is in contradiction, or your decision-making is in contradiction to universally accepted models and values and so forth, and in red, again causing harm, or are in conflict with an individual's rights or values, or the organization for which we work, the values of that organization. More specifically, we consider conduct as unethical when it breaches ethical frameworks or our professional standards, when it prioritizes personal or corporate gain over that of patients, or in the case of organization, that of employees. So if patients' well-being is compromised, or employee safety is compromised, when we have wrongful prioritization. Also, if our conduct is unethical, when it is incongruent with our inner character, or it contradicts our own moral conviction. And this is when we experience moral distress, and I'll talk about that a little later. Now, unethical conduct is not always intentional. Sometimes it happens when in the least or the most unexpected ways. But let's look at what do we mean by intentional. So conduct is intentionally unethical when we knowingly go against ethical principles. So for example, engaging in wrongful practice or decisions that ultimately cause harm to the patient. Unintentional is when there is a temporary failure for us to act according to ethical principles or values, and we call that an ethical lapse. And this is particularly common in acute care environments, in the emergency care environment, where it's not deliberate or intentional to breach an ethical concept, for example, not getting a patient's consent to intubate or whatever the case may be. Failure to recognize our implications or the consequences of wrongful behavior, and that we then also call blind spots. And these are unintentional ethical conduct. Now let's hone into the context in South Africa, why ethics really matter. Now, ethics in practice, whether it's medical practice, nursing, pharmacy practice, is fundamental for ensuring patient safety, dignity, and autonomy. And I'm going to look at two broad areas: contextual challenges, and then what I call the 3 Ps, and they are imperatives: political, policy, and professional imperatives. So let's look at the first. So colleagues, there are many things that challenge us in South Africa, but one of the big ones is resource constraints. And this is around, I'm going to single out only 2, and this is about human resources. There is financial issues as well, but also physical resources and supplies. Now, in the resource area, human resources area, we are very acutely aware of the critical shortages of nurses. And one looks particularly at the number of registered nurses. There's a big shortfall of about 62,000 nurses in this country, and half of that fall in the category of registered nurses. Midwives, very, very crucial. Our ratio of midwives to population is fewer than 3 midwives per 10,000 population, and that is way below the global average of 4.5 midwives per 10,000. And colleagues, the reason I raise this is because if we do not have the right skills and qualifications and competencies of our nursing colleagues, then it definitely will compromise the kind of care that we give. The same around specialties. I believe that there are specialty shortages in both the medical profession and the nursing profession. I read the other day that urology seems to be seriously compromised, in that on the HPCSA register, we have fewer than 350 urology practitioners in the country, and that is quite serious. The attachment to that was, of course, the ability to manage and control cancer, particularly in prostate cancer. Equipment and supplies, very briefly, this also affects if there is unavailability of equipment, unavailability or short supply, particularly if the other day we spoke about blood, the ability to transfuse blood timeously, and also when there is equipment failure, these are issues that creates moral distress in health professionals, in that you know that this should be done, but it cannot be done for this particular reason. Let's look at diversity. Now, apart from the health condition of our patients that already put them in a state of vulnerability, we are confronted with many other sort of imbalances where the patient comes in and is not considered in the same way as you consider others. So we look at diversity factors, including age, which is quite a big one, race, ethnicity, nationality, and many of those other factors which makes you so on the one hand it's a blessing, but on the other hand also a challenge. And if we do not have a natural propensity to embrace diversity, then it is very important, and more increasingly organizations embark on diversity training to ensure that we do not inadvertently become unethical in the way we treat people who are not the same as us. Violence and harm against healthcare workers or healthcare professionals. If we read the latest or the 2023 SAMA report, you will see that harm and violence against healthcare workers are hugely on the increase, particularly in the past decade. And the consequence of that is that health professionals then become traumatized. They experience both physical and psychological trauma, and that in turn can erode our ability to care. It can erode our ability to be empathetic, and that in itself borders onto unethical practice. Let's look at the private health sector in particular, very briefly. We know that the private health sector, of course, is governed by market logic, and it should never be an instance or cases where financial or sustainability pressures supersede the rights and the quality of care that patients should receive. And so while that is very important, one must resist the temptation to cut corners for the benefit of the organization in exchange for the benefit of the patient or even the staff. So the sun doesn't always shine on our practice, and sometimes these challenges then give rise to storms in our practice, and this then may lead to ethical dilemmas, ethical risks, moral distress, and conflict of interest. And these are hugely problematic and compromises health professionals' ability to provide quality and ethical care. So let's look at the 3 Ps, and I will not go into detail in all of these. We will talk about the Constitution of South Africa, the supreme law of the country, and how that impacts on our conduct. Batu Pele principles I will just mention, because even though NGOs and the private sector is not obligated to embrace Batu Pele principles, it is encouraged, particularly because the private sector is a major role player in the provision of health services. And so we try and encourage NGOs and private healthcare facilities to embrace these principles, particularly in their service standards, in access, in openness, and in terms of value for money. So I'm going to look at some of these. We'll look at the Patient Rights Charter and also not interrogate the national policies, but just to say that there are many, and there are just a few examples that help us to guide the way we practice. Just in terms of our professional bodies, there are ethical codes and scopes of practice. And what sometimes happens if nurses practice out of their scope that is defined for a particular category, that then can also compromise the type of care that we render to the patients. And maybe this, for some of us, is an event that happened many, many years ago. Upon graduation, we all, as health professionals, take an oath that we will always practice in an ethical and in a professional manner, apart from all the other things that we say at the time. So it's worthwhile remembering that as we go forward. So let's go to South Africa's Constitution. We all are aware that worldwide, South Africa is lauded for its Constitution. It doesn't always translate into practice, as we see currently, but we cannot ignore the fact that it is well regarded globally. And the reason for that is because at the center of our Constitution is human rights. So it emphasizes ethics as a core component of South Africa's democratic values. It specifies the interconnectedness of ethics and human rights. And if one looks into the Bill of Rights, you will see there that the Bill of Rights really is the cornerstone of our democracy, protecting fundamental human rights for all citizens in the country. And I'm very tempted, and I will do that, including non-citizens, because we see what is playing out in our country, and this in itself can cause ethical dilemma and for some moral distress in the healthcare fraternity. So these core democratic values are human dignity, equality, and freedom. And I would like just to drill down into those values. They are extremely important. Now, if we value human dignity, it stems from the belief that every person has inherent dignity that must be respected and protected. And if we value that, we will treat patients with the respect and give them the protection that is needed. If we value freedom, we believe that every person has the right to basic liberties, such as the right to life, the right to privacy, freedom of expression, freedom of movement, and the like. If we value equality, we are vested in the belief that everyone is equal before the law and that we should refrain from unfair discrimination based on all of those things that I'm flighting there: race, gender, nationality, sexual orientation, and the like. These values are inextricably linked and almost is the foundation of ethical practice. So colleagues, how do these rights then apply to patients? I'm flighting there on the right-hand side, the Patients' Rights Charter, but also important to know that the HPCSA also has taken directly from these the Patients' Rights Charter their own rights charter, as you can see there, titled The Guidelines for Good Practice. Now, many of these rights are self-explanatory, and some of them are quite loaded. So I'm going to not go through all of those, but take a few, particularly the loaded one, and I'm looking at access to health care. Now, when we consider access to health care, it doesn't just mean opening the door to your healthcare facility and not discriminating against people. What it does mean is that once a person is in the healthcare facility, that they have they have access to timely care, access to the most needed emergency care, and that when they actually receive the treatment that is needed, that treatment will be carried out in a dignified manner, and also that they will be received by healthcare professionals who are courteous, respectful, and so forth. So when you look at the Patient Rights Charter, access to healthcare is quite loaded. Healthy and safe environment is quite self-explanatory. And if we look at to be treated by a named healthcare professional, we require health professionals to know the names of the patients that they treat. In the same vein, a patient can expect to know the name of the healthcare provider that treats. So whether it's a nurse or a doctor, it is important that you are known to the patient that you're treating. Participating in decision-making is also not loaded, but quite vague. But what that essentially means is that the patient should be provided with enough information to be an active participant in deciding whether to agree and go with the treatment plan or to not to go with that. It also means that the person, that you as a doctor or a nurse would then tailor your treatment according to what is needed by the patient. Refusal, I think, is quite explanatory and similarly being referred. Now, on the flip side of the rights, there's also a list of patient responsibilities, and one of the most important ones that stand out is compliance with prescribed treatment and anything else that goes with it. If the patient is at the tail end of his or her hospital stay, any rehabilitation or recovery procedures that is prescribed. And so that is quite an important balance to the rights. So I just put this in for good measure because I find that young professionals, being very rights conscious, often ask, do we as health professionals have rights? And the answer is yes. But often these rights must be balanced against very significant, we cannot override the legislation, very significant legal and ethical duties and responsibilities. And one example, the Nursing Council is very explicit about the rights of nurses. And a right that stands out very strongly for me is the right to advocate on behalf of the patient where there is need for that. And I would encourage other professionals, I haven't gone into detail there, but to see if your professional body like the HPCSA also have an explicit rights charter for doctors, physiotherapists, and so forth. So codes of ethics, there's a code of ethics provided by the Nursing Council and also by the HPCSA. And this is really, as you've already learned, a declaration by health professionals to always provide due care to the public and healthcare consumers by observing and applying core ethical principles. And we will go through these principles in details in a bit. Now, both the Nursing Council and the HPCSA embody those core principles, but there are additional ones which are very interesting and important. Altruism, which is concern for the welfare and well-being of others, and this is very, very fundamental to our ability to care for people who are vulnerable. Caring, definitely an indisposable principle, and compassion, which the HPCSA actually very nicely, I find that the Nursing Council didn't spell that out clearly, but definitely in the HPCSA document, you'll find that compassion as a core principle, meaning being sensitive and empathetic with patients in need, and in accordance, provide comfort and support in that regard. So the core ethical principles, I'm just looking at my time. Autonomy. What autonomy really means is that we have respect for patients' self-determination, and that is so that the patient can make informed decisions and choices about their health and so forth. And together with that, to ensure that we provide the patient with the necessary privacy and confidentiality about the decisions and the choices that they've made. Beneficence, self-explanatory, means that we do good at all times, in all the actions we undertake, that all the decisions that we make will always be in the best interest of the patient. The flip side of that coin is do no harm. And thinking always precedes what we do and what we say. And so even at that level, our thinking should not be harmful. What we utter and say to patients, what we write, should not be harmful. And then, of course, the actions should also not incur harm to patients. In terms of justice, that means fair, equal, non-discriminatory treatment, non-discriminatory attitude, relations, again, verbal utterances, none of that must express unjust or unfairness towards the patient. Veracity is about honesty and being truthful in all actions, including how we communicate and how we share necessary information in formal channels. Fidelity, about loyalty, maintaining loyalty. If you make a promise to a patient, try and keep it within reason. Honor commitments to patients. Those all speak to the principle of fidelity. Now, again, I've cherry-picked only 4 just to illustrate how these ethical principles govern or inform our practice. In autonomy, I'm using the example of informed consent. Observance of autonomy requires us to provide full information, sufficient, complete information to patients about their illness. After all, it's their illness, it's their body, even though the treatment plan is decided predominantly by us as health professionals. But the patient needs to have full information about his or her illness, what treatment is planned, what complications can be expected as a result of treatments, what are the possible prognoses, and here what we mean, full disclosure is required. What happens, and here I'm just thinking of two areas where we are sometimes challenged in autonomy, is particularly in end-of-life decisions, and where we tend to run the risk of futile care, and this often needs a multidisciplinary or a team discussion in this regard. Where the patient has a living will, or there's an express not to resuscitate instructions, we must, at the best of our ability, observe these. Then, although consent covers in uneventualities, any unplanned surgery, for example, in a non-emergency situation, which I'm sure we remember, it's called surgical creep, is also a form of breaching patient autonomy. Let's go down to justice. Here it requires us to allocate resources and maintain the standards of care according to nothing else but the clinical need or the condition of the patient. No otherness, like the patient's age or the patient's nationality, must determine how we allocate resources and exercise our standards of care. Very much married to justice is the notion of advocacy, where standing by or being a bystander to unjust practices is tantamount to being a part of that. And so we must be encouraged and have the courage to speak out and not be voiceless in the face of unjust treatment and care. In veracity, let me just do this. So unjust treatment is tantamount to a breach of a fiduciary duty, and it can also breach the doctor-patient contract, or also the doctor or the nurse-patient contract and relationship. Deviating from practice standards that is expected of us is tantamount to nursing or medical negligence. Looking at documentation in veracity. Now, veracity requires patient records to provide contemporaneous, complete, accurate, and objective, truthful account of a patient's condition. And colleagues, this is quite an important matter that pervades our practice, whether you're a pharmacist, a doctor, or a nurse. If there are colleagues of the risk committee on this webinar, it's something that causes tremendous ethical risk, not only to you, but also to the Clinix group. If we look at illegible records, that is tantamount to passive obstruction of truth and compromise care, the continuity of care. If we, for some reason, have to erase or delete things that we've written, that may constitute falsifying facts and destroying evidence. And there are, of course, guidelines which we must use to, if we've made a mistake, to correct or to delete aspects with the appropriate signatures and so forth. When we look at fidelity in practice, it requires us to be true to our word or promise to the patient. And this, colleagues, varies from a very basic need, like providing a patient with a urinal or a bedpan, or if you've promised the patient, I'll bring a bowl of water so you can, and I'll assist you with your hygiene need, to follow up post-operatively. If the patient has had post-operative surgery, we should not be, and it's actually called abandonment, leave the patients unduly for a long while before post-operative follow-up happens. So patients expect that, and of course, it is required of us then to stick to what is expected. So what this means is that you must do what you say. That helps to build trust and good interpersonal relations, and also mean what you do, which will be an illustration of your integrity and authenticity as a health professional. Colleagues, just very briefly, a generic ethical decision-making framework. If one is confronted with an ethical issue, it's important to adopt a team approach to this, because often we find that colleagues are isolated in managing an ethical issue. Important to gather all the facts, figures, and around the data that you need, and also at that point to identify all stakeholders, all people that's involved or may be impacted by the ethical issue you've identified. This also means that it may at this point involve the family or the patient at this point. Very important then to establish if there's been a model conflict. Just hold on, please, tell Derek not to make a noise. Establish model values that have been contravened in this regard, and sometimes the ethical decision-making framework, your ethical decision-making ends here. But it's very important that there's a collective effort in dealing with a breach of ethics. If it continues around the cycle, it's very important that we apply our guiding ethical principles and consider aspects of the 3 Ps that we've talked about. Then consider the best solution, but also the consequences or the possible outcome against that solution, which we then implement and act upon. And very important that we consistently document what we're doing, and then also, according to institutional policy, you will escalate and report accordingly. Dr. Kanoshi, I'm sure there's time for these 2 case studies.
Yes, yes, please,
Doc.
You can,
yeah,
Prof, you can go ahead.
For you. Thank you.
No, please do go ahead until you finish.
Yeah, sure, thank you. I'm going to allow people just to quickly read that. It's a very basic one, but something that crops up all the time. All right. So this is about confidentiality. And here we may be tempted to respect the patient's wishes, autonomy, but also what is the consequence of not telling the partner what is your responsibility towards public health or broader health in society. So you need to consider the ethical principles here at play, and also what course of action you will take. And I have just listed a few ethical principles that that's at stake here: autonomy, confidentiality, not causing harm to the patient, because as you can see, there's a threat of violence, fidelity, and any other ethical principles that you can think of. The learning points here for us, and the take-home messages really, is about patient confidentiality, which is foremost, and it can only be compromised if there's legal criteria met for disclosure of the patient's status. Other learning points is fidelity, where we, as reasonable as possible, to be true to the patient's request. But we also see this in context, and that there is, in any case, threat to the patient's safety. And so safety planning or making having protection for the patient is essential, and that will involve or entail referral to social work and or counseling services, and also to communicate and escalate this as per hospital or clinic's policy. The second case study, again, just a few seconds to read. So this is about ethical responsibilities and rights here, and maybe this doesn't happen often in the clinic group, but we as nurses know that this does sometimes happen. And what we really should be looking at here are the responsibilities of the two professionals involved here. The ethical principles that come to mind are justice. Remember, we talked about not using or allocating resources for anything else other than the need or the health of the patient, advocacy, altruism, and there's the caring ethic. The learning points we take from this is that financial pressure or resource constraints do not override the patient's welfare or well-being. In terms of the nurse's scope of practice and their rights, they have a right and a responsibility and a duty to advocate for patients, particularly if there is concern for the well-being of the patient. This situation obviously calls for collegial discussion to reach a decision or to reach consensus. And so, colleagues, it's not always necessary to follow the ethical decision-making framework, but sometimes having a discussion, interrogating why the nurse is feeling or raising that particular issue, looking at the data that's before us, and then have a discussion around that. Should that not happen, it's important to escalate and report using the formal channels and guidelines of the institution, and always protect yourself through proper and complete documentation. Colleagues, my penultimate slide here. Ultimately, ethics do matter in practice, and the patient is at the center of ethical practice. Patient safety and quality, here we see that ethical practice, grounded in non-beneficence, ensures the best possible care and outcomes for our patients. Ethics ensures that patients' rights, cultural beliefs, religious beliefs, sexual orientation, and so forth are respected throughout their period of care, and that they are treated as individuals, not just as cases or diagnoses. Ethics help us to, or ethics in practice help us to build a strong ethical foundation of trust between patients and us as health professionals, and this is absolutely vital for effective care. Ethical principles help health professionals to navigate complex situations where model issues arise, especially in life and death decision-making. Ethics help us to retain professional identity and maintain standards, and it helps us to make consistent, morally sound decisions, enhancing the reputation and the identity of your respective professions. We need model courage and support. And so if we abide by the ethical values and model values and ethical principles, it enables us to handle model distress far more intuitively. It helps us to advocate for patients and confidently stand up against questionable practices. In closing, ethics is not optional. It's your or our professional duty. Ethical lapses, as we've mentioned earlier, often start small. It should never be ingrained in our practice. Silence can be unethical. Good documentation is ethical practice. You or we are accountable to patients, to the public, to our employers, profession, peers, and so forth, the laws of this country, and lastly, and not least, nourish and nurture your ethical practice tree. Thank you, Dr. Kanoshi and colleagues. I've also attached a list of references for people to have a look. Thank you.
Well, thank you very much, Professor Bruce. And you can see all the applauses on the screen. I think this was a fantastic lecture. way beyond what I thought. I'm sure I'm not the only one who people think that I've heard it all about ethics. I know it all, but I think after this is until you heard this lecture today that actually we know not so much on ethics. There's still so much to learn. And I think, Prof, you've given us exactly what we need to know. I see quite a number of messages in the chat box, people asking for a copy of your presentation. Our policy is that we usually ask the presenter if the presenter would like to share, and we don't send to all, we send to all those who ask for presentations, and usually send a PDF presentation on with consent of the speaker. So those who would love us to send them a copy, they can always email us on webinars@clinix.co.za. Webinars@clinix.co.za. I think
Dr. Kenoshi, what I'll do is, sorry to interject, what I'll do is, because I'm an old educator, I have animation, so I'll just deal with that and then send it to you again. Okay, thank you.
All right, thank you very much. I think, but still, people can ask, and then we'll respond to all those who send us email, who send us this thing. So we will go through the questions that I can see in the chat box. And Tolakele, please, I won't be watching the hands, the electronic hands. So if anyone raises a hand, please let me know so that because some people may want to put their questions or comments orally, they're welcome to do that. We'll unmute them and they can do that. Okay. Let's start with the first one. Prof, I see there's one from Becky Hadebe, consent form. How can you take a patient to, I think, theater? I think they wanted to say, without a consent form, it is a norm that patients will sign will sign at the waiting area. I think they should sign long before that. Any comments about consent forms, especially for theater?
Oh yes, I fully agree. It shouldn't happen there because in any case, you need to have a solid witness for what you're sharing with the patient. I think if the patient's already at the door of the theater and you're now getting up what we call informed consent, it's already an abuse of our power as health professionals. And it should happen way before, unless it's an emergency where you may have family members having to sign. But in an elective surgery situation, it's important that informed consent is obtained way before the patient or way before they're en route to theatre.
I think that's a very important point. There's a question also, how can healthcare workers, especially nurses, be protected from being verbally abused by their MDTs, multidisciplinary team members, I suppose, those who they work with?
I'm the wrong person to ask because, and I didn't even want to go into bullying when I spoke about the stuff of confronting health professionals. I think nurses are very bad in standing up against that, and there is no reason why a nurse should not say, listen, please do not speak to me like that. And actually, the institutions should create a culture where nurses feel safe to be able to deal with such issues around bullying and know how to handle it. But I'm the wrong person to ask because I was a second-year student nurse when I challenged a doctor. And of course, I got into serious trouble for that. So there are consequences for one's action, but you've got to learn to be courageous and stand up and protect yourself. There's nobody else who's going to protect you. That's
I
for the
think
nurse.
I think that's very important. If I may ask one question, Prof, you know the issue of ethics and the being included in a curriculum for both nurses and for doctors. It might already be covered in the nursing syllabus extensively. But I think in the medical schools, how can we advocate for its inclusion in the undergraduate in undergraduate studies?
Yes. So you're absolutely right, Dr. Kanoshi. The ethics is a very underserved discipline in our curricula across the board, across the board. Now, if you look at how the nursing programs are designed, one of the graduate outcomes, and one of the what we call the exit level outcomes, is ethics and ethical and professional practice. And so if you've not demonstrated how that is then rolled out in your curriculum will not be accredited by the South African Nursing Council. So I think it's important for teachers in the medical curriculum to look at to what extent that is covered in the curriculums and advocate for a stronger presence of ethics within curricula. Now, I know at WITS there's a concerted effort to have it as a theme in the medical curriculum. And also since the establishment of the Center for Bioethics, we have those ethicists then coming in and teaching in the medical curriculum. So I think, yeah, I fully agree. There's lots of opportunity, and we've got to lobby constantly for ethics to be better foregrounded in our curriculums.
That's right. There's a question from Elena Sirokolo, who says, and maybe Ms. Sirokolo could, Dr. Sirokolo, I'm not sure, could maybe unmute and explain this one, unless if you'd understand it, Prof. She says, what must we do if the patient forces us to use what is above our power to help him or her? So the patient forces you to use what is above your power. I don't know, unless if you understand the question, yeah?
Yeah. I'm not sure. I can't even think of an example right now. But it's important to have an open discussion with the patient. And of course, if it's an unreasonable request, and it would be interesting for the participant to give us an example, it would be important for a doctor or a nurse to stand their ground and say, I'm not permitted to do that in terms of my ethical code or my scope of practice. I can't really, Dr. Kanoshi, I can't think of an example here.
Yeah, maybe Elena can raise her hand, will unmute her, and she'll be able to put the question more clearly so that you can understand if she's not answered. But let's take this one from Professor Dirk Duplessis. Professor Duplessis says, thanks, Prof. Bruce, for the systematic analysis. The sad reality is that all of humankind does not universally have lots of empathy, compassion, which is why there are many laws and regulations and rules in an attempt to enforce ethical behavior. It is also a problem. Values and morals vary a lot in our country, and even more so in the world. What would be your comment, Prof?
I would 100% concur. If you remember my analogy of the tree, the root and the values, I mentioned that values change over time, and there's so many factors that rattle the roots, rattle our values. And sometimes, if you have to ask me what was my most difficult aspect to teach in my more than 40 years of teaching nurses, is that if someone doesn't have the fundamentals in place of how to care and how to respect people, it is very, very difficult to teach professional caring. So I don't have the answer, but I can point out the problems. And I think one of our biggest weaknesses is that we do not properly select the people who come into the health professions. I almost want to make a blanket statement and saying, if you don't have a caring bone in your body, if you are not concerned about the health and well-being or the vulnerability of people, you almost have no place in the health professions. And I know people will counter argue because there are strands of health professional work that do not involve engagement with people. But caring is so foundational. And unfortunately, we look around in society, we see the erosion of those values right in our faces, and we can do little about that. And perhaps training and training and training will help, but if your heart is not in the right place, there's very little we can do.
We should refine the ways in which we sift entrance into the healthcare system applicants. I don't know in whatever way, but I think you are so correct, Prof. Let's see, this one is from our physician, Dr. Alice Kanyinza. Dr. Kanyinza says, how do we deal with a patient nurse? A patient nurse. So this person is a nurse, but also a patient as well, but she's a qualified nurse. A patient nurse who is reporting you daily to management and calls nurses names. She's a patient, but she thinks she knows it all.
Oh,
Yeah.
It's a hugely unprofessional conduct, and perhaps it is important to have a conversation with that person. It does place the burden on the doctor to be more detailed in the way they would obviously explain, because this is a health professional who will expect detailed information about their condition, what they're going to do, what the progression is likely to be, and so forth. But I really think, again, that it is not proper for somebody who's a health professional to dabble and is now a patient to de-roll from being a professional and really use the hospital as a place for treatment and recovery. And it perhaps requires a discussion with the management, with the patient involved and the doctor concerned. But that's very distressing. I've never heard of that. I know that health professionals uh, uh, more broadly can be difficult patients, but difficult in the sense that they require far more information than your regular patient who's not a health professional. And you must be ready to answer all their questions.
Very difficult situations. Dr. Kizito Machache is a physician, is a pediatrician, actually, pediatrician. He says HIV disclosure among partners is challenging, but manageable, How should I handle a situation where the mother wants the doctor not to disclose the HIV status of a minor child to the child's father? So this is a mother and a father. The mother knows that the child is HIV positive, but she doesn't want the doctor to disclose it to the dad.
To the dad. I'm sure there's the Child Care Act. I'm not sure if it's still called the Child Care Act. I'm sure there is leeway in that, because the health of the child is important. So if there's going to be treatments or stuff that needs to happen to this child, depending on the status of the child, how will the mother then exclude the father from that process? So again, I think it's taking cognizance of our guardrails, the ethical principles, and go to the Child Care Act and see what the provisions are in there. The other thing, as I've emphasized in my talk, is really to have a team approach. It is not fair, I think, for somebody to have a heavy ethical burden and be allowed to really sit and try and tease out for themselves what is the best solution. And so I think within the hospital context, there has to be some or other forum or an opportunity for doctors who encounter such difficulty to be able to talk through it and come to the best solution.
Yeah, that's right. There's a note from Dr. Naledi Mutupi who's correcting us there, Prof. Yeah, he says actually ethics is now included in MBCHP in the
Yes.
undergraduate study, which I'm happy to hear.
Yeah.
So this must be probably in the later years. I hope it's the same in the 10 medical schools in the country. And he says lecture series in bioethics start from as early as third year of MBCHB now. I think that's great news, and I hope that's universal. That's right.
Yeah, no, Dr. Matupi, we're not disputing that. We're just saying that it should be foregrounded better than what it currently is. And the most important thing about a theme like ethics is that it should be spiraled. It should start from day one, and you spiral it in terms of its complexity throughout the curriculum. But it's very encouraging that more and more medical schools are actually formally placing ethics within the curriculum. Thank you for that comment, Dr. Matupi.
Yeah. There's one from Becky Hadebe. I'm not sure whether it's a doctor. He says, Becky Hadebe is a doctor. He says, how can a doctor book a patient for a specific procedure and end up doing something else not aligned to the to the procedure signed for, in the consent form? And also the scrub nurse proceeds to scrub, for the wrong procedure. Well, I've heard this. Before you respond, Prof. I've come across at least two occasions where this was done with the consent of the patient, for medical aid purposes. If a medical aid scheme would be prepared to give authorization for this procedure, but not for that one. So especially the cosmetic procedures that they don't give authorization for. And then the nurse and the patient and the doctor would collude to I think it's. I don't know whether Becky Hadebe is referring to such a situation as well, and so that they do the procedure with wrong and consent form and authorization, but they know that they're going to do a different procedure. Any comment from your side, Prof?
Yeah, I mean, sometimes it becomes unethical, but there are preceding things that should happen, not following protocol or procedure, and all of those then culminate in unprofessional and unethical practice. And as we've said, and I use the example of surgical creep, this case that Dr. Becky mentions is obviously one where there's a collusion and some party benefits from that, and that is outright unethical practice. How we manage that, I don't know, but safe to say that should not be allowed, and particularly if there's collusion from the theatre nurse or the ward nurse, the anesthetist, whoever is involved in that procedure. Hugely unethical.
Okay, I'm just checking for other questions, but I think we've dealt with all of them, except Dr. Opaitete says, Prof, how can we be certain about an 18-year-old matriculant without coaching to answer questions or promote oneself in an intake interview? I'm not sure whether you understand that one, Prof. Okay.
In an intake interview, I didn't get that.
Yeah, it says intake interview, but maybe Dr. Obaitete can please explain that. You can unmute yourself and explain your question. Dr. Opai, Tolakele in the background, if you see Dr. Opai, you can unmute him so that he can put his question.
Okay, can the doctor please raise his hand?
Okay, but in the meantime, whilst if he's going to, if Dr. Opaitete is still with us, let's take Dr. Stanley Mhlongo, who says, Prof, kindly comment on an approach to deal with RHT by parents of a minor in terms of advocacy. RHT being refusal of hospital treatment, you know, I think in this case, the parents would be taking the patient, the baby or the child out of the hospital, and the child can't answer for him or herself. How would you, what would be your comment on that?
Yeah, now I must speak under very strong correction because I'm not in practice anymore. But from what I recall, is in that case, minors are protected by the Child Care Act. But before we even get to the legislation, it's very, very important that the doctor has a sit down with the parents or the mother, or whoever the case may be, to really disclose and give full information about the consequences of their decision. Because it's always about trying to persuade, and I must emphasize here, not coerce, but trying to persuade the parents and for them to really exercise autonomy. They need full explanation of what the consequences will be in the case of refusal. But colleagues, and I'm sure there's somebody on the webinar who can confirm, minors are protected. In the case of refusal, minors are protected, and that's your first guardrail.
Thank you very much, Prof. Before I take the next question, which is from Prof. Ruda Mativa, I think let's go back to Dr. Opaitete. I think the hand is up. Can you unmute, Prof? Dr. Opaitete?
Yes, good evening, Prof. I was thinking in respect of when you said the intake, when you are interviewing patients in intake, doctors in intake, so that if people are not ethical in their belief on their bones, they shouldn't be accepted to medical school. How do you do that at an interview for an 18-year-old?
Yes.
Bearing in mind the complexities of our society. Thank you.
Yes. So that was really a tongue-in-cheek comment, because we know that it's not been done. And the main reason for that is that it cannot be done. We cannot determine the person's level of ethics or the level of caring at the point of entry of any kind of program. So the reality is, Dr. Emmanuel, if you are a doctor, is that it can't be done. But the difficulties that we encounter in later life when we're exposed to such professionals don't bode well for the healthcare team, and neither does it bode well for the patient, because then you will persistently be faced by complaints against healthcare workers who are disrespectful, who are uncaring, who are negligent of their duties, and so forth. So if there was a way, and yes, society is diverse, people are brought up in different ways, but the reality is it can't be done. And for that reason, we are unable to determine the person's caring ethic at the point of entry. But it does come out later in the program as they begin to learn about their respective professions. I hope that answers your question.
Thank you very much, Prof. I see a hand from Dr. Gavanda, but let's take the question from Professor Rudo Mativa. Good evening, Prof. Rudo. Prof. Mativa says, can you address the role of ethics when care is futile?
Yes. Yes, thank you, Prof. Mativa. We know each other from WITS. It's lovely to hear you on the chat. Yeah, futile care is one of those gray areas. Now, I've recently had a situation where a very close friend of the family had a very high C3 fracture. He could not do anything for himself, paralyzed from the neck down. And he had an explicit wish not to be intubated. Now that causes already moral distress, because you as a doctor and a nurse know that that is going to enable the patient to breathe, oxygenate his cells, and so forth. But there was an explicit wish from the family through the patient that he did not want that. Yet, the care was continued. They put him on a ventilator. That is where futile care really plays out. It was not going to change anything. And so, Rudo, I am not sure about what balances our decisions at that point, other than the autonomy which is through a living will or through the patient's family delivered to the health professional. And for months, patients then hang on knowing that the outcome is not going to change at all. And it causes enormous moral distress to both nurses who must look after the patient and to the family who visits the patient. So at all times, we must observe that. And it's one of the most difficult, we talked about end of life and this futile care. It's one of the most difficult things we have to confront as health professionals.
Yeah, that's a difficult one, Prof, because, the healthcare professional also thinks, they've got a conscience as well. Should I let this person, would it be neglect if I let the person die, pass on, without me doing this and doing that to save the life? But also there are issues of medical legal litigation. If I don't do it, if I don't intubate, then I may be charged by either the Health Professional Council or by, in the courts. It's so they try to do everything that they can so that they're not found wanting in their care. They don't want to be found negligent. It's very difficult.
Yes, a very important. I want to call it a statement, but there's a nicer word. If you haven't documented what you've done, it's considered as not having been done. And so in this regard, I would really encourage all doctors and nurses and whoever is dealing with a patient to document every step, even if it's not at the time, but immediately after, the discussion you had with the family. What were the outcomes? What were the decisions? Because I can tell you that will stand up in a court of law. It's hugely distressing for everybody concerned, but you've got to document what you do and your interactions with the family and the patients during such difficult decisions.
Very important, especially the documentation part. And Prof, there's a hand from Dr. Vanilla Govender. Dr. Govender, you can unmute yourself and go ahead, please. Tolakele, can you assist Dr. Govender?
Good evening. It's actually Sister Vanilla Govender.
Okay, hello, Sister Govender. You can go ahead, please.
Welcome.
Thank you for excellent webinar, Professor. I must say that it was a good refresher. And furthermore, like I said in the chat box, I've been a seasoned nurse for 44 years. And I must say, across the board, both in public and the private sector, ethics is gone out the window. In not all cases, but in most cases.
Yeah.
Nurses, I'm speaking on behalf of nurses, nursing care. Nurses are there mainly for the paycheck. They have completely forgotten about Patients' Rights Charter, the Barker Peerless principles, and like you said, the core components of ethics, which we were taught as first-year student nurses. And it is actually very, very sad to be admitted to patients and witness what goes on in these hospitals. especially, particularly with the elderly and vulnerable patients.
Yeah. I can only agree with you. I can't add anything more substantial, but to agree. And really, it's about individual accountability and conscience. And if that can't guide you, then of course, nothing else will.
Thank you.
Yeah.
Okay, thank you. Prof, just the last few questions. There are two that look and that actually look the same, but I think Nobile Dladla says, good evening. Is it ethical to write the patient's HIV status on an ICU chart? And I think I saw another similar one down, which is coming just now, saying the same thing. Is it also asking whether it's ethical to write the patient's status? But on that one, it's on the health. They call it the health card. You know, the patient's the health card, but on an IC chart or anywhere in the patient's records, is it ethical?
Yeah, I would not think it's necessary, because there would be enough data, or somewhere in the documentation it would be written that the patient is HIV positive, and nurses are have access to those records. And so when we write things down, it must be for a particular purpose. And so if the status in the patient's, let's say the progress report or on the ICU chart, if that is of no consequence to the purpose of why we're documenting, it should not be documented. So it's and I know that ICU charts are less and less available to the public. If it is purposeful, I would think yes, but I do not think it should be explicitly stated, particularly if your ICU charts are still visible to others in the ward. But it doesn't mean that we should hide the HIV status, because there are consequences for those actions as well.
Yeah. And I say those that are visible, because in more and more healthcare facilities now, ICU chart are digital, are electronic, and only those with a password and access would be able to access them. But in ICUs or hospitals where they still use hard copies, then it could be visible to other people. So I think that question also, does it also apply to Stella Onyari's question? She asked about the road to health chart, which is normally given to the patient. No? Would you put HIV results on a road to health chart?
I don't think so.
Yeah, as long as it's explained to the patient. But how would you guide if you are a doctor in a hospital and this patient is going to receive his or her ARVs at clinic level, they need to have all the information.
Yeah. And also, I think very important, if you remember the slide where I showed how many policies and guidelines there are to guide our decisions as health professionals, go to the HIV policy. It talks about testing and the permission and confidentiality. That's very, very important, that we also become more open to those guidelines and actually use them to inform what we should do and what we shouldn't do. So I don't explicitly, I can give you the broad principle, but in practice, it needs to be informed by those guidelines.
Okay. Well, thank you very much, Prof. I think most of the questions have been answered, but those who maybe I haven't seen, you can still email them to webinars@clinix.co.za, and we will pass them on to Professor Bruce. I'm sure when she finds time, she'll always answer your future questions if you have any. Thank you very much. I think at this stage, Prof, I think we had at the top of attendance 631 attendees today, which is a good number.
Wow.
So surprise, I've got Professor Jeff Wing waiting for next to me.
Oh.
He's going to do the commentary and vote of thanks.
Okay,
Professor Jeff Wing. Professor Jeff Wing, please.
Okay, thank you for allowing me to do this, Dr. Kenoshi. Professor Judy Bruce, it's Jeff Wing here.
Hi, Jeff.
So in our former lives, in the faculty, I'm going to say a big thank you to our assistant dean. As been mentioned, ethics often is fobbed off among many medical people as too soft. You know, it's soft and soppy, as opposed to the hard, technical, molecular bit of medicine. But as Dr. Kenoshi mentioned, we can never have enough of ethics advice, particularly in this modern age, where the technical part of the human being, the artificial intelligence of treatment is emerging. And as you mentioned, that humanist aspect of us is lost. So, I thank you for reminding us that to be a good doctor, a good health practitioner, we've got to be a good human being first and foremost. So I'll thank you, Assistant Dean. And then as a colleague, Sister Bruce, Judy Bruce, I want to thank you again, because I certainly remember that when there is teamwork and communication, particularly between the nurse and the doctor, the patient outcome is always more favorable. And in my former life, if it wasn't the fact that I had good nursing colleagues assisting me, my success rate with patient care would have been far worse. So I think it also raises the humanness of us working together as teams. And particularly in this day and age, the clinical team with that human spirit running through it with good communication is going to be good for the patient. So I thank you both as Assistant Dean and a registered nurse in reminding us of all these important aspects of what good health practitioners should be doing. So thank you very much.
Thank you very much, Prof. Wing, for your kind words, and I think Prof. Bruce deserves every word you said about her and academic career. I think, Prof, this was very enlightening to everyone. And I would like to thank also all people who took time out to attend this lecture. I think it was worth it. Prof, we can see all the applauses on the screen. Let me also thank the technical team in the background. Tolakele, she's with now, and with Sister Nessisa as well. Thank you very much, and have a good evening. So we meet again next week, Thursday. We will have another webinar, the same place, same time, 18 hours. Thank you very much, and good evening to everyone.